It's my pleasure to welcome you today for the very first event of our new Mental Health Ventures series. This series was created and launched by Harvard Mental Health. I'm Marie-Christine Nitzi. I'm the president of Harvard Alumni for Mental Health. And we've had an increasing interest on the part of our members, including from students who are graduating this May, who are joining us very soon in the alumni community, who expressed an interest in getting some exposure to work that was done by mental health professionals at the intersection of mental health and technology, the intersection of mental health and the business world. And so it's my very great pleasure today to introduce you to our Director of Science, Embry Thompson, who is gonna, in a second, introduce our honored speakers for tonight. We are so glad to hear from them and from the app they created and the impact it has on a lot of women around the world today. So without further ado, thank you for coming. We're excited to hear about your ventures at the intersection between mental health and business. Feel free to put where you're coming from and what your ideas are in the chat box. And please, Embry, take it away.
Hi, everyone. I'm Embry, and I'm the Director of Research for HUM. I have the pleasure of having Anne Wanlund and Dr. Alex Kelman join us today to talk about their app. They're called Canopie, and it is a digital platform that's designed to provide therapeutic techniques recommended for preventing and treating common maternal mental health conditions. And so I just want to give a quick bio of our speakers today. So Anne Wanlund is the CEO of Canopie, a company making effective mental health support a standard part of care for expecting and new moms. Before Canopie, she led several maternal health focused organizations in East Africa. She has worked in global health for the State Department, USAID, and Mass General Hospital, and has a master's degree from Tufts University, where she also served as a teaching fellow at the Harvard School of Public Health. Anne channels her passion for working on maternal health and personal experiences as a new mom to address the enormous mental health care and treatment gap that affects millions of mothers every year. Thank you, Anne, for joining us today. And next up, we have Dr. Alex Kelman, who is a licensed clinical psychologist who is currently director of training within the University of California, Los Angeles. And he, in his dissertation research, Dr. Kelman conducted an internet-based randomized controlled trial assessing viability of a novel compassion training program for currently pregnant, intending to become pregnant, and postpartum women. In addition to this work, Dr. Kelman collaborated on projects and manuscripts related to the Mothers and Babies Internet Project, an internet intervention created by Drs. Aline Barrera and Ricardo Munoz. Some of Dr. Kelman's collaborative work in this domain led to manuscripts assessing novel methods of recruitment using Google AdWords and evaluating ways to garner quantitative and qualitative feedback from a global sample of women in order to inform how best to tailor subsequent versions of the EMB internet intervention. Dr. Kelman also has clinical and research interests in mindfulness, meditation, compassion, health equity, and trauma-informed systems of care. That was a mouthful, but that's because our speakers are so accomplished. Thank you both for being here. And I guess I will hand it over to you guys to talk to us a little bit about your app and the work that you do.
Thank you so much, Embry. And it is such a pleasure to be with all of you here. And then I know this is being recorded, so if you're watching this later, thank you for watching. This is such a real treat for me because Alex and I have never actually done one of these presentations together. But we would not be Canopie without Alex, and it's not just because we prioritized, using research and evidence in our design, but his work really represents, I would say, the kind of heart and soul of the feeling that we're trying to create for, birthing parents who are going through a very big transition in their lives, a very vulnerable time that is quite difficult, and for which we don't really have enough support in our current society. So I'm going to quickly run through my presentation, but Alex is really the star of this show, and I hope this isn't too dry. I hope this is, I'll try to keep this as interesting as possible. And the great thing is that we have fun graphics on our slides. So at least there will be good images too, and very excited to share this. So Canopie is really we're a mission-driven company. As Embry mentioned in her introduction, our goal is to make maternal mental health care just a standard part of pre and postpartum care, and we can talk about how we're trying to do that. We are blending the research and patient perspective in how we're approaching this issue. It's really, really important to us that we do both of those things, because motherhood is a very specific time, and the way in which we experience anxiety and depression and really the other mental health conditions as well is very specific to the transition and the unique things that are happening physically and kind of in our lives at that time. We designed Canopie to, as much as possible, be placed to reduce health and economic inequities, and I can go into that more if there's interest. And then we really wanted to create a complete solution. There are many, many challenges with how behavioral health and physical health are delivered in our healthcare system. They're, sort of at odds, and often behavioral health is an afterthought or very difficult to access, and not through how we are getting our physical health care, our traditional health care. And so our goal is really to bridge that gap and be a solution to that big challenge. So the way we talk about this, there's so many angles here, right? But we talk about maternal mental health really conditions as really being the most common complication of pregnancy and childbirth. They make preterm birth 3 times more likely. They're extraordinarily costly in the US, which is how you get people in healthcare to pay attention. $18 billion, it's the highest costing medical and non-medical maternal morbidity. About 70% of new mothers struggle with their mental health, and Black and Latina moms are much more likely to struggle and also less likely to receive support. And about 85% of us don't access any care or treatment for how we're feeling, which creates a significant burden on health systems. So why does this problem persist? It's a few, there are a number of reasons, but part of it is if a new mom is screened, she isn't necessarily going to even be honest on that screen, because it's a highly stigmatized issue. The solutions are often not really wanted. Having the diagnosis in general feels like a form of judgment. And a lot of people just assume, well, I can just kind of put my head down and get through this. And I would put myself in that bucket. And then, OBs and pediatricians feel really uncomfortable with this process because there are a number of reasons: not having enough time with the patient, but also lack of effective resources, and not even really knowing what happens with a mom if they connect her with care. And moms on Medicaid plans really fare the worst. About 50% of new moms are covered by Medicaid, and they will wait 3 months before they can see a specialist. That's the average, and a lot can happen in that time. So when we created Canopie, we actually really didn't want to create an app, but that is what people wanted, and it was because our phones are a really easy way to access care. It's transportable. We'll often have access to internet on our phones, but not necessarily in another way. And our goal was to make sure that whatever we were delivering was evidence-based, scalable, could be multilingual, totally accessible, inclusive, low cost, which is connected to scalable, and to feel like a gift, to feel like something wonderful if you feel like you're in a very dark time in your life. So we have a screening at the start and the end of the program, which is able to connect a new mom with emergency support if that's needed, but it's also a way for us to measure baseline and endline scores so we know how effective we're being. We do education and guided practice and journaling. It's video and audio and text. And we tried to make sessions really short because sometimes you don't know how much time you're going to have, especially if you're dealing with a kind of resource constraints or time constraints or human constraints in your household. And I mentioned the mobile phone and the app thing, but the research is really, really clear on new moms wanting to engage with care on their phones, and that almost everyone, if they do have access to a mobile platform, engages between the hours of 6 p.m. and 8 a.m. And that's because that's often when we're struggling most and sometimes when we're awake and have nothing else to do. So we did our own program evaluation, and I'm going to quickly go through this so that we can get to Alex. To make sure that what we were doing was effective, we conducted it internationally, and we saw that the Canopie program was really effective for especially moms who had possible symptoms of higher scores on the Edinburgh postnatal depression scale, so indicating possible symptoms of depression. And we did it cross-culturally, and English as a second language for most of our participants, and many of them, almost 60%, identified as low income. So before we decided to even launch this, we tested it to make sure we were on the right track in terms of what we were delivering. We also really wanted to make sure that people, the perceived value, not just the clinical value, but the perceived value, that people really thought that what they were getting from the content of the app, the program, was really valuable, that it helped them, because sometimes those things aren't in perfect alignment. So, for us, we're trying to integrate as much within existing care channels as possible. So our goal is to introduce support as early as possible. We think that there is a huge opportunity, and this is, Alex has worked very closely with Ellen, as Embry mentioned in the bio. Ellen Breer is also our science advisor. She runs the Mothers and Babies study, which is really about prevention. And their work has shown that about 50% of perinatal mood and anxiety disorders or maternal mental health conditions are preventable if you can intervene with something effective early. And so our goal is to really, improve maternal health outcomes overall and engage healthcare stakeholders by averting downstream costs as well, and just do it as much as part of prenatal and postpartum care as possible, especially because expecting and new moms are supposed to be screened by their OBs and pediatricians for mood disorders. So we have a range of wonderful partners that we've been working with. Canopie, was vetted by the American Academy of Pediatrics, so we're a STAR Center resource, which makes it a little bit easier for us to work with doctors. We're connecting with moms who are at the NICU at Children's National Hospital, for example, and we're very, very fortunate to have partnered with the Mayor of Washington, D.C. To connect moms in DC with Canopie, which has been just wonderful, because there's some other great maternal health programs that we've been able to partner with to get them access to Canopie. And we're also working with health plans. So now I'm going to turn it over to the wonderful Dr. Kelman. And I'm very happy to answer any questions later. But he is going to kind of talk about really show the real value of Canopie in his talk.
Great, thank you so much, Anne. As Anne mentioned to y'all, this is the first time that we've gotten the chance to really do this talk together. And it's really such a joy to be able to do this with one of the Anns, the other co-founder, Anne, who's not here right now. I had the joy of meeting these folks a few years ago and kind of hearing about their ideas of really scaling and trying to sustain these maternal mental health interventions. And for others, either in this room during the live event right now, or those of you who are also watching it later on a recording, I feel like the folks who've done research probably have also felt sometimes the constraints of academia in terms of sustainment of resources that can be helpful. I think often we're really good at deducing where folks can derive benefit and seeing kind of what works and what doesn't work, and can sometimes not be great at taking those things and sustaining those within systems of care, especially when you talk about complex systems of care in the US, globally. I mean, you have just so many different channels that need to be moved through that inevitably you need really kind of, scaling and sustainment minded folks. And so for me, it's such a joy to get to work with Anne and Anne on this as a clinical content advisor, and to, learn from them about the ways in which, we can partner with various institutions, with cities and districts, as Anne has mentioned. And so for me, I think one of the things, and the reason I wanted to start with this piece is, one, just to express that gratitude, and two, I think, reflecting on the function of this series that y'all put together, I feel like mental health is now, I feel like more than any time, at least I've seen, evident in kind of, private sector and venture capital, and people are really interested in scaling mental health interventions. And I think that there are inevitably going to be some concerns of how these things get scaled, just when we're talking about systems and structures that have problems and inequities built and baked into them. And concurrently, leaving these things fully in academia doesn't allow them to ultimately best serve people. And so I feel like we're in this really interesting time period where mental health is getting some of the limelight that I think other, aspects of our health, our physical health, has gotten in the last several years. And we're starting to see these percolations of like digital mental health programs and interventions. And, for me, this is a really exciting time, because I think the reality is I think all of us know, is that, mental health is not something that we have or don't have. Mental health is something that exists along a continuum. And, my mental health can surely kind of take dives throughout the same day and lifts throughout that same day. And so, more than ever, especially with the movement of a very fast-paced world, we need, I think, a lot of kind of supports. And I think there's also a lot more turning towards. At the time of this recording, so this is in May of 2022, one thing that really stands out to me, just as a really interesting and hopeful point, is, albeit in a very divided country, we have, I think recently there was a statistic that 9 out of 10 Americans believe that we're in a mental health crisis. And of course, I'm not arguing that it's a good thing to be in a mental health crisis. There's a lot of deferred maintenance we've done on our mental health system that has allowed for us to get here, mixed with then a recent global trauma of a pandemic. And at the same time, having, I think, that awareness and people noting that, I think can be a driver for action to happen, right? I mean, and so in some ways, like, that statistic to me, albeit, very, very sad in terms of the number of folks that are suffering currently, I think also reflects a time point in which people, there's will, I think, to do things about it. And so I'm really grateful to be here kind of in our small part, cultivating our garden through Canopie. And, you know, as Anne mentioned, I'm a clinical content advisor for this work. I was previously director of training for a center at UCLA, and I'm currently working at a Canadian biotech company called Cybin, doing some work on psychedelic assisted psychotherapy, drug research. And so, I've had a varied career so far. And, I think like the pieces that tie my kind of work so far together have been around scalable mental health resources. And so I'm really grateful to get to be doing this work at Canopie along now with my advisor, Alin Barrera, who Anne mentioned, who's really, along with Ricardo Munoz, both just luminaries in this particular field. And the work that I've done in my small part is a comparative randomized trial looking at a CBT intervention. So for folks who are not from mental health disciplines, cognitive behavioral therapy, which is the gold standard intervention generally across depressive conditions and also within perinatal depression, and comparing that to a compassion-focused therapy intervention. And I don't want to get too much into the weeds, although I'm happy to talk to folks at other points or after. But my hope today is not necessarily to give like a full kind of accounting of the various components of Canopie and the differences between, but really to talk about these three components. So we have cognitive behavioral therapy, which, as I mentioned, the gold standard of therapeutic intervention for depression. We have interpersonal therapy, and then we have compassion-focused therapy. All three of these have been researched within the context of perinatal mental health. Compassion-focused therapy is the most novel of them, and Michelle Cree and Paul Gilbert and other folks over in England have done a lot of work to get this kind of, both depression as well as perinatal and postpartum depression work off the ground. And what I'm hoping to do with y'all, both the audience that's here with us live, as well as folks who are going to be participating asynchronously later on, is just to ask you for just several minutes, instead of us really talking about the differences between these or highlighting kind of why we took the approach we took. I first want to do, if folks are okay with it, just a brief experiential to kind of walk us collectively through, how, Anne mentioned about the program really being imbued with like that internal tone, how we talk to ourselves. And so I really want to focus a bit on kind of how we really address that internal tone within the Canopie program. Because this is just for folks, as we're talking about this is an asynchronous resource, which means that folks are walking through this in a self-guided way. And so they're not necessarily having contact with others, across the line. They're on their phones, on the app. And so, a big piece of this is like, how do we structure the language? How do we structure the tone of the language in a way that allows for folks to access it? And so before saying anything else, I'm going to just ask that folks, either eyes closed or open, totally up to you. Just take a couple moments and just like watch your breathing. So I'm going to close my eyes, but again, you can do whatever makes you feel comfortable in this moment. And just to give you a heads up, we're going to walk through two very brief experiential practices with a slight variation between them. So just, again, whatever level your comfort is, eyes closed, eyes turned down, eyes open, and then just tracking the breath, watching the inhales come in and watching the exhales go out. And then again, you can do this with your eyes closed or your eyes open, but just try to imagine the contents of your mind like leaves on a stream. And watch as the leaves float down the stream. If you get caught on a thought, let it go. If you find yourself distracted, bring your awareness back. So just focus on the leaves on a stream. If your mind goes somewhere, bring it back. If it's hard to focus, and bring your mind back when your mind is able to come back. And just keep watching those leaves. And then we can let go of that first guided imagery of the leaves floating down the stream. And what I'm going to do now is just very, very briefly take us through that exact same activity, but give a couple extra prompts to kind of help remind us to check in with how we're talking to ourselves about the tracking of the leaves on the stream. So, again, you can keep your eyes open, you can close them, you can turn them slightly down, whatever makes you the most comfortable here. And just start to notice your breath, watching as you inhale and watching as you exhale. And then imagine the contents of your mind are like leaves on a stream. Maybe you can hold this image in mind. Maybe it's hard to find this image. Just kind of notice where your mind is right now. And watch your mind as it tries to engage in this activity of tracking these leaves on a stream, knowing there's no perfectly right way to do it. Sometimes at some points, the mind is going to flow in various directions outside of your conscious control. And that's a function of what the mind does. But just, as you're able to, and, when you can, just bring your mind back gently to those leaves floating down that stream. And if you get distracted, that's also okay. Just notice that distraction and gently, bring yourself back to that focus of the leaves floating down the stream. And we can just take one kind of deep inhale for the folks who would like to here. And then one deep exhale. And those were both almost the exact same activity. In both experiential activities, we were briefly just watching as the mind kind of tracked leaves as they would float down a stream. But in the second experiential activity, I gave extra prompts about the tonal dimension of how we're talking to ourselves about the activity. And so really kind of engaging with not just the contents of the mind, so not just the tools of the mind, but also the tone. And so for some folks, it might have gone just fine. You might have noticed zero differences between the first experiential and the second experiential. I know for me, I am very kind of attuned to the tone in which I talk to myself, and it can have a big impact. And in terms of populations who struggle with or at risk of depression, there is a tendency to interpret negative or neutral content as negative. And so what that means is, we might be talking to ourselves or listening to something or reading through something that is neutral. It's completely neutral in terms of the language, the grammatical structure. Everything is just it's a neutral thing we're engaging with. But when we're struggling with negative affect and low mood, we have a tendency to interpret neutral stimuli as well as, of course, negative stimuli, but most importantly here, neutral stimuli, neutral content as negative. And so what that really means is that we need to double down on the tonal dimension of how we engage with ourselves in moments when we're struggling with negative affect, with low mood. And so, a lot of what we really have tried to do in the Canopie program is to keep a central focus on that tonal dimension, which isn't always included in some of these interventions. And so, I think it's perhaps helpful to think about, cognitive behavioral therapy and interpersonal therapy, which can be really excellent tools and interventions that can be immensely, helpful for people's mood management. But sometimes where you can, leave something missing, especially in digital mental health, is in that tonal dimension. So while CBT and IPT really have those tools, you need additionally the tone of how you speak to yourself in order to really kind of help you kind of manage the inevitable self-criticism and shame that comes up not just as a function of your depression, but as an adaptive function for a species whose very survival is contingent on us, doing right by the tribe. And so in order for us to really feel like we're doing kind of things in a way that's congruent with like how we want to be in the world, we have shame and self-criticism that function as kind of corrective mechanisms. And while not necessarily always helpful or fun, they're part of our genetic inheritance, right? These are transdiagnostic things that you see across clinical presentations, which means that for self-criticism, you'll see that with depression, with anxiety, with all kinds of mental health struggles, and with struggles that are just inherent within being human that don't even reach clinical significance. And so really like where we're trying to focus on here and what Canopie is really doing with compassion-focused therapy is using the various components of compassion-focused therapy, which is really an evolutionary rationale for self-compassion and compassion for others, to help people understand that often their shame and self-criticism, which for perinatal folks can be such a part of the presentation of symptoms, is not, theirs to hold. It's a function of a genetic inheritance that, came with us, that are the minds that we're built with. And so it's really externalizing some of that struggle and seeing that struggle as something that's not a function of something, inherently deficient in you, but rather, the genetic lineage that we come from. And also, the realities of, just systemic inequities and other facets of a culture that has not done right by moms to hold, perinatal folks into, in a place where we have enough of these kind of programs and supports where we can even accurately assess how many people are suffering. I think the information Anne went over on just the limitations of our very ability to assess kind of maternal mental health needs speaks to, real kind of gap in the US as well as globally of treating folks. And so, just to kind of reiterate here about Canopie specifically, what we're really kind of working with is both the tools, those immensely valuable tools that are offered through cognitive behavioral therapy and interpersonal therapy, tried and true interventions, alongside the tone of compassion-focused therapy to kind of create this ecosystem of interventions that have both the tools and the tone, so that when perinatal folks are walking themselves through the app, that there's a tone of compassion imbued within how we speak through the app, how the words are written, how the meditations are recorded, how the emails are sent. And so really trying to target not only the tools, but also really working with that tonal dimension to try to help people change a little bit their internal tone, right? Because one of the, really kind of tricky, pesky parts of depression and just, low mood and negative affect is that, it's self-perpetuating. And we often can go down these spirals of I'm bad and, here's all the reasons I'm bad. And once you're kind of in that thought loop, it's really, of course, hard to get out of that thought loop. I know for me it is. And so, really kind of what the ask is here, or rather the offering is a program that allows for folks to kind of walk themselves through the tools and learning about the tools while holding this compassionate tone, and then teaching about ways to, through meditation, through other practices, to monitor the self-critic, to engage that compassionate tone in service of being able to manage mood. And so I'm going to pause here. And then I don't know, Anne, if there's anything you want to add to that, or if we want to open up for questions or.
Oh, I hope everybody enjoyed that as much as I did. I think Alex just can demonstrate really what we're trying to achieve with Canopie and how he is talking about the issue and explaining how we're using it. And I don't think had we not if we hadn't met Alex and come across his research, I'm not sure that we would have gone ahead with a digital intervention for perinatal mental health conditions, because it was so important for us to address that missing something that we just kept seeing in other interventions. And it was amazing when we encountered it. We were like, okay, yeah, this is it, this is what actually has been missing for us. And yeah, so grateful for that.
Thank you guys so much for taking the time to share with us all of this amazing work that you're doing. This is like really near and dear to my heart because I am an aspiring OB-GYN. And I feel like this is definitely an area that is and has been overlooked in the past. And if you don't mind, I have a question. And then I will obviously open the floor to our audience to also ask questions. But I'm wondering how, like, whether you have this app in mind as like a proactive or reactive resource for mothers, and depending on which one, how you intend to navigate the stigma surrounding like having help from any resource. So like, how do you plan to like share this with mothers and like, kind of break through that barrier of like shame or stigma? Like, what are your plans for that?
Great question.
Yeah, that's a great question. Was that for Alex or Anne? Sorry.
Either one. You both actually answer if you'd like.
I feel like, Anne, you can best speak to this. I feel like you and Anne and Nan really are the guiding forces of the sustainability, the scalability of this. So I'm going to totally defer to you, and I'm happy to expound on anything you'd like me to touch on that would be helpful.
Thank you. Yes. Well, I can tell you where we are now, which is primarily it's sort of proactive and reactive in a way how moms are currently being connected with the app, because we're the physicians who have been most interested in Canopie or tend to connect moms with Canopie are seeing some struggle or risk factors like NICU, having babies in the NICU. But we're trying as much as possible to intervene or really be connected with moms as early in their care as possible, because the truth is it becomes much harder to start doing things for yourself once you have a new baby. And the techniques are really effective for prevention too, but it's also very hard for us to do things that are before we're struggling. So the way we try to get around that is by, you know, a lot of personalization and focusing on very, very common challenges and worries. And so that no matter where you are or what you're thinking about, you're probably going to find something that really, really resonates with you. If you're, you know, struggling with sleep, or maybe you're worried about how having a baby is going to affect your relationship, or if it's, you know, you're worried about your baby's development, the really common things. And it's a bit of a Trojan horse effect. We're trying to make sure that, you know, and we try really hard not to use language that could be stigmatizing or labeling in general. We are dealing with a pretty tricky balance of being as kind of clinically correct as possible, while also being as kind of personal and human as we can to try to bridge that gap, because the core thing we're trying to address really is stigma and shame, and that intertonal work that Alex was talking about is just such a huge part of that. And then kind of the other gap is we all struggle, and these are all the things we're struggling with, and it's very, very, very normal and common, and this is what we can do to, you know, as part of the care we can get.
Thank you for answering that. And so, yeah, I'd love to open it to the floor to see if anyone has any questions. If you feel comfortable like unmuting yourself, feel free to do that. Or if you'd rather enter a question in the chat, please feel free to do that as well. I could ask another question. I'm wondering if you guys have any insight into like change or like differences in mental health needs for mothers who've gone through like live vaginal births versus cesarean sections, like if there are any differences there, and if so, like how do you address them?
I can start with a half answer to that, which is what the research shows, but what we've also seen with so we have, you know, at this point several thousand data points that we can look at, but the key is really the expectations versus reality part of motherhood, which is we all have, it's impossible not to have some expectation of what things are going to be like, and we're even encouraged to have things like birth plans, and you know, and there is inherent and we really get into this as part of the compassion focused therapy and the evolutionary stuff that we talk about in the app, but there's just a lot of judging that we naturally do as that part of this time of ourselves, of others, and but it can be really unhelpful to how we feel. And there are certainly, we all have visions of what a good birth experience will look like. And there is, you know, believe it or not, a little bit of shaming around C-sections, you know, oh, it's not a real birth experience. That's how some moms feel. And that's how some, you know, it's kind of the message that some of us get, which is just, you know, really, really heartbreaking. So it's more, I think it's more, I'm not sure if there's anything else in the research about this. I mean, there's certainly some stuff around kind of the kangaroo care and stuff like that, and kind of the bonding and what you're trying to trigger. But it's really the expectations, versus what ends up happening, and those things are never in alignment when it comes to motherhood. So Alex, I don't know if you have anything to add to that.
Yeah, no, I don't have anything specifically to add in the context of, the various, kinds of delivery and birth. And I'm really glad, Anne, that you knew some of that research base. And I guess what comes to my mind is thinking, kind of through the kind of compassion focused therapy lens. Right. I mean, there's so many sociocultural expectations that we put on perinatal folks and how the birth should go and how happy you should be and all of these templates, right? That are some, things that we pass along, at a species level, and that's a species level culture. Others that are a function of the cultures in which we live on nation, on county, city, ethno-racial levels. And so all of these various kind of templates that, are kind of placed on our experience of what it means to give birth and then to be a parent and to be a new parent. I think this is where a lot of this like compassion focused work really kind of can help, folks to separate some of the expectations that are passed along to them from what they ultimately kind of in their heart want to happen for them and their babies. And so some of the hope with like this, compassion focused work is that people have a space, that is an internal environment to better kind of look at some of these expectations that get passed along to them so that they can recognize and then hold those in an internal container where they can then kind of decipher what pieces of this do I want to keep and what pieces of this are not serving me. And of course, there's all kinds of, work that has to be done to untangle things that are systemically rooted. And so there's all these various levels of, being able to accept while also needing to take, action in places in advocacy where you need to. But I think kind of, the kind of short answer from kind of my standpoint on compassion focused therapy piece of it is that like this internal tone, this internal environment that, we're hoping to help folks kind of create and sustain gives them a space to kind of notice some of those, ideas that are getting put onto them by other people about their method of delivery and some of the things that they take in both overtly through friends and through family, as well as through implicit and explicit messaging and culture, that people have kind of a kind of an evolving kind of, hopeful practice where they can hold in mind kind of what can I do, or rather, how can I like, look inside and see what really is right for me. And then, just hold that internal tone in a way that kind of allows people to create the space to experience that.
Thank you. Thank you both. I think we had a question from our audience. So I think Mohammed raised his hand earlier. Mohammed, if you want to unmute yourself.
Sure, Ambry, thank you. Like I said in the chat box, this has been truly inspirational what you and Alex have been dealing with, because that is a very important and salient topic and has been overlooked in the past, as you stated. The fact of the matter is that perhaps you might be, thinking of at extending or advancing this kind of, software application, whatever we're going to name that, but that is going to be in the fingertips of the people who are going to be not only perinatal, not only be used as the perinatal tool for mental health, but even gestational mental health. I mean that many of the mothers, they unfortunately experience some unplanned or unsuccessful gestation. They have abortion. They might be going through hard time having the IVF, or they might be having kids with predicaments afterwards. And as you stated, they are struggling with so many difficulties after, birth of their baby, including sleep insufficiency and also dysregulation of the hormones and immune system and stuff. So by that, mental health is health. So we're putting that into the perspective of the neuropsychoimmunoendocrinology. So why not to think about even a wider range of audience for this outstanding technology, outstanding tool to address some of the other target groups, including not only, mothers, but parents, both because they are, just facing a whole new situation at the birth of the baby, and also specifically mothers who are having some background in neuropsychological or cognitive problems, and they are going through the gestation. They have the baby delivered, and afterwards they are going to suffer from the mental health issues. So that was the point I wanted to mention, and just to uh, you know. Uh, congratulate you for the success you've already made and suggest if you'd like to take it even further to target a wider range of audience. My wife, she's a gynecologist, and I'm a neurocognitivist. So we happen to see many patients that they are suffering from the shared context of predicaments and issues. So that is kind of, making sense in some of the instances. I don't know what you think about that, but just want to thank you once again. Brilliant job.
Thank you, Mohammed. It's I'm going to find a way to reach out to you after the talk because I'd love to talk more. But we're thinking on exactly the same lines. It became really clear really quickly how cross applicable a lot of these techniques are, and our goal was to really just make sure we were getting it right for kind of a specific subset of people first, and learning as much as possible before pushing out on either end. And I guess I shouldn't even say that. It's kind of a 360 thing too, because as we do that, we also want to make sure that we're going deeper. So doing it, really just expanding the circumference of what we're doing. But there's such great need. You could think of it as kind of reproductive mental health, but it's really these mind-body intensive transitions that are really overlooked, and our focus has been so squarely on physical health for so long that I think we are getting to the point where people understand that mental health is health, but we're really not there yet in terms of how our system and how we pay for things, or how what the expectation is, and certainly stigma. So there is a lot of work to be done kind of on that end too, but we are thinking about the same stuff along the same lines. So
Thank you for your question, Mohammed. We have a question in the chat as well. I think the person who asked it actually had to leave the Zoom room, but we can answer it in case she's watching later. But I think this question is for you. So she says that she has very professional interests other than being a faculty or clinician. In her time at Harvard, she started working on a tech venture to target treatment for Korean adolescents and sense of belonging. It seems like, though, as you said, that academia sets you up for either of the two aforementioned options. What has it been like for you to work more in industry / a non-conventional route?
Oh man, I love this question because I feel like this has been on my heart and mind recently. There's a really interesting kind of thing happening now with many academics, many psychologists, many physicians in moving outside of traditional settings and utilizing the skill sets that we have in industry. And there's just been a massive kind of shift that we've seen, of course, right, in so many different sectors of our global economy, with this great reshuffling, I think is what folks are now calling it, as opposed to the great resignation. But I think my individual experience has been really kind of interesting for me because I didn't expect to necessarily take the route of moving to like an industry position, both in the Canadian biotech and then also, getting this opportunity to work alongside Anne and Anne. I think my kind of conceptualized trajectory was, I think, the template that I had in my mind based on the psychologists before me, which was, yeah, you either hang up a shingle, you become faculty or clinical faculty at an institution, and then you do your blend of research and clinical and teaching. And I guess for me, I was finding myself, so I'm still clinical faculty at UCLA, so I still have the opportunity to work with students and to be involved in some academic work. But for me, I was really finding myself, especially during and not like towards like the latter part after kind of COVID, of wanting to do things that really moved a bit quicker. I think I'm feeling a bit of this, urgency that I don't know if others feel as well, but just like a lot of the structures we've built kind of our institutions on. Not that this is newly discovered for everyone, or not this is even new, but this is shaky ground for many things that we've built in society. And I think for me, finding myself bumping up against some of the limitations of academia. I think there's a lot of beautiful parts to academia, but I do think one of the limitations is that it can be really hard to, again, take that work that you're doing and be able to provide it to folks in a sustainable, scalable way that can be monetized so that it can be sustained and so that it fits within, again, all of the structures that we have in place that are necessary conditions to allow for something to perpetuate. That I think for me, it's been really interesting. It's been really interesting, and I will say that one thing that is very notable for me is that I've noticed that in industry as opposed to academia, at least in my individual experience working on clinical drug trials for deuterated, so derivatives of psychedelic compounds, is that alongside psychotherapy is like one of the major parts of my work is that it's a lot of focus on a couple things. So like in academia, I found myself doing a lot of different things, and I think there's a lot of benefit in that. But I'm finding for me that I'm doing kind of well being able to focus on just a couple of different things and really kind of dive deep into those in a way that at least academic medicine was harder for me to do those things. So I know that's verbose. I hope that answered your question.
Thank you, Dr. Kelman. I think we have time for one more question. We have one more question. So I think Chang is raising his hand.
Thank you so much. Yeah, I really enjoyed this talk. Thank you so much for sharing your fascinating insights. So I wonder if you can talk a little bit more about the business side of your venture, about if you must have interacted with lots of venture capitalists, and so what's your experience? Who do you think, from your perspective, who are the top venture capital funds in this mental health industry, and if you could share some of your process of raising capital, venture capital, some successes, some lessons learned, that would be great. Thank you.
Yeah, that's a great question. And there are, I would say, because mental health has become, and Alex was really getting into this, which is it's very, very helpful context. Mental health ventures have become very, very interesting. I mean, for a few years now to venture capitalists. So I wouldn't even say, there are some venture capitalists who only really focus on mental health and behavioral health. But what I think is happening is that a lot of venture capitalists who were healthcare investors or health tech investors before have absolutely just added mental health and behavioral health to their as a vertical that they're looking at. But what's a little bit different is that there, and I think this is kind of reflected in like regulatory issues and everything too. It's that there's just a lot of gray area between kind of what is a, there's a digital therapeutic space, there's the wellness space, and then there's kind of everything in between. And then there, venture capitalists who are very, very happy to take on research and long FDA cycles and stuff like that. And then other investors who are not so interested in that and are more interested in the consumer facing. So it is I'm very happy. I can probably talk all day long about this. But the process of raising capital, I think, has been it's been probably easier because we're working in a field that people are interested and excited about. Although I would even say when we started talking to investors, everybody said to us, "Oh, maternal mental health. Wow, that's so niche." Which nobody says that anymore, which is at least that's something. But even in the last year, that has really changed. I think people understand this idea of we're just getting a lot better at understanding that that broad solutions, and there's space for a bunch of different kinds of ways of accessing support, including things that are much more focused on a life transition or a specific kind of condition or experience. But I actually think that it for me, because we have raised a pre-seed round, that my lessons were a little bit more about like the kind of the profile of investor that we really wanted to have with us, who really understood the value of what we were doing and our values. That was a really big one. And then also just fundraising as a woman was very interesting. So if you're ever planning on raising venture capital, I will very happily share all of my my lessons from that. So please do, I'm going to put my email here in the chat. But I'm very, 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 very happy to talk more and extensively about this. It's very interesting.
It's wonderful. Thank you so much.
Yeah, my pleasure.
Thank you, guys. And I don't know, Mohammed, if you also wanted to share any, or if any audience members want to share their contact information, feel free to in the chat. But this brings us to the end of our event. Just want to be mindful of everyone's time. But thank you all so much for joining us today. And thank you, Anne and Dr. Kelman, for joining us and for telling us about your work and Canopie, both the medical side, the business side. There's so many different facets of this kind of work. And it really does take a team to bring something like this to life. So thank you. And thank you for thinking of people who, in a way that they haven't been thought of. I feel like mothers really appreciate you thinking of how, like, the things that they're going through and how to help them. But yes, thank you so much.
Thank you.
Yeah. And thank you for everyone who's watching this in the future. I hope everyone has a great night. And if you haven't seen in the chat, there is a join us form for Harvard Alumni for Mental Health. If you're interested in joining, if you are not already a member, feel free to join.
We'll have, as we're continuing this mental health venture series, we're actually creating a cohort of those of you who are attending those talks, who are launching your own ventures. We're grateful for our speakers to share their contact information, and we're building a community there of people interested in mental health and ventures in the business world. So thank you to our speakers. Thank you for all of you who are going to be the next generation of these products to support mental health around the world and facilitate access to care. Thank you again, Embry, for hosting our event today. Thank you, Anne. Thank you, Alex. And see you all soon for a future Harvard Alumni for Mental Health event.